undertaking stakeholder consultations. And the focus is on private healthcare, which comprises a very complex set of interrelated stakeholders who interact in various ways and who must interact in order to provide this service. In fact, those intersections and interactions are the ones that cause a lot of complexity in dealing with the sector. So the inquiry tried to break it down into three main groupings of providers. The first one dealing with healthcare facilities. These will be mainly hospitals and day hospitals. The second one being providers. By providers we mean specialists as well as general practitioners. There are also other providers like nurses and so on, but these two are the most significant from an expenditure point of view. And then the third category is that of funders, which are, in the case of South Africa, largely medical schemes as well as medical administrators. There are also brokers who play a role. The structure of the healthcare system, which also played a significant role in us deciding to do the inquiry. We have in South Africa a dual system of healthcare. We have a public sector which is accessed by about 84% of the population, as well as the private sector, which is accessed by about 16% of the population. And we also, if I may refer to this slide, you will note that the number of people who access private health care, and these are people with medical insurance, has remained stable from about 1980, and so has not increased that much, whilst the number of people who are reliant on the public sector has been increasing steadily over that period. We also note in the background that these two, that is the public sector and private sector in healthcare, consume approximately 50% of the total health expenditure.
So 16% effectively of the population that accesses medical care through private health care utilize 50% of the available resources for health care. South Africa as a country spends about 8% of GDP on health care, which is comparable to developed countries, OECD countries in particular, and is higher than most developing countries. So if you are benchmarking us against those countries, you will find that we are spending on average what is recommended as a best practice. But what we have is a distribution problem and not the total availability of funds for the sector. I have already set out the various players in the sector, but I've provided a more substantive slide that describe for you who are in the funding side of the bucket. We know that these funders are the ones who would compensate either the practitioners for the service provided or the consumers, where the consumers or patients paid out of pocket. And on the other side is the practitioners who would ordinarily claim from the medical funders using a practitioner number, and we will explain the implications of that as we go along. We also have noticed that some of the facilities, which is the hospitals in the private sector, are not allowed to employ doctors, but there are doctors that are based at the hospital, so at the facility itself, and we will talk about what the likely implications of these are. We also do have some of them who own shareholding in the facilities. That also has some implications as far as the incentives of contracting with certain providers is concerned. So my colleague will proceed from here.
May I interrupt you for a second just to ask a question about the work that the panel has done and that you've done? Do you know anything about the racial demographics of both practitioners on the one hand and scheme membership on the other? Or do you know where one would find that?
Perhaps my colleague may have an answer to that, but as far as I know, we didn't collect data on the racial profile of people involved, but my colleague can maybe help with that.
Thank you, Chair. We, as the Commissioner has mentioned, we haven't broken down the distribution of practitioners by race, but we understand that generally there is a lot of practitioners that are GPs, black practitioners or practitioners that are from historically disadvantaged backgrounds that are largely GPs, and then specialists. There is where there is a shortage of specialists. Okay, so I'm going to go deep into how the practitioner market is structured. These are central to the consumption of healthcare services. They generally comprise of GPs, specialists, allied practitioners, and pharmacists. Our investigation focused largely on GPs and specialists because they account for the largest population of practitioners and the bulk of the healthcare expenditure. Practitioners operate in different forms of practice. You've got solo practices. This is where a practitioner will have his own individual practice. And then you have group practices. We largely find those, for instance, radiologists and pathologists. They will have group practices. And then they organize themselves in practitioner associations that would exist to represent the interests of the practitioners. And then some of them are employed in the public sector, but those that are employed in the public sector and wish to practice in the private sector, they operate through RWAPS agreements. These are the remuneration work outside the public service. And then for practitioners to practice and to be reimbursed and verified in the sector, they need to be allocated a practice number through the BHF's practice numbering system. And then in terms of regulation, they're regulated by the Health Professionals Act. So it identifies and classifies and states the roles and scope of practice for the different practitioners. This largely happens through self-regulation in terms of the ethical rules by the various professional boards. So you would have a professional board for pediatricians, for gynecologists, and the like. In terms of the distribution, our analysis, this is based on 2015 figures. There might have been a slight change, but we don't think that the figures have changed materially. And as well, we noted that in South Africa, there is no proper data collection method. And as such, it was very difficult to verify some of the figures, but these are the estimations that we could collect. So we found that totally between the public and the private sector, we've got 0.3 medical practitioners and 0.1 medical specialists per 1,000 population. And then when we focus on the private sector alone, we've got 1.75 private sector practitioners per 1,000 insured population. And then the GPs are distributed relatively even across the insured population at just under 1 per 1,000 population. And then we find that the specialists are more concentrated in provincial hospitals and metropolitan area. So in certain areas, particularly the rural areas, we don't have specialists at all. So the referral have to go from rural areas into the metropolitan areas. This is just a graphical representation of the medical practitioners per province. I mean, it's just to emphasize the point that we're making that it's largely the metropolitan areas or provinces that have a large number of practitioners, and it cuts across the board. So in terms of the industry interactions, the practitioners are the point of entry into the healthcare system. Ideally, the healthcare pathway to the private healthcare starts with the visit to the GP. So the GP will assess the patient's condition, diagnose and recommend treatment of the condition. And then if necessary, then they would refer to the specialist for treatment of the condition that they have diagnosed. And then if the condition requires admissions of a patient to the hospital, then the choice of the hospital will be influenced by where the specialist is practicing. However, our analysis found that in South Africa, this pathway is not necessarily followed, where we find that patients have direct access to specialists and have direct access to hospitals, which we find that it's also a driver of healthcare expenditure, in that the role of the GP in particular has been minimized, and primary and preventative care has also been minimized. So there's a lot of hospice-centric treatment happening in South Africa. And then practitioners have specific relationships and interactions with other players. But before we get to that, we just want to show in particular on the funder side, the market shares. So we've got two types of medical schemes in South Africa. We've got the open and the restricted medical schemes. In terms of the open medical schemes, we've got 4 main players, which is Discovery, Bonitas, Momentum, and BestMed. This is based on the number of beneficiaries. And then on the restricted medical scheme side, we've got 3 main players, which is GEMS, PALMED. Oh, sorry, I forgot to mention the market shares. So Discovery, in terms of the open medical schemes, it's at 56%. Then you've got Bonitas at 15%, Momentum at 6%, BestMed at 4%. And then the restricted medical schemes, we've got GEMS at the top at 46%, PALMED at 13%, and BankMed at 6%. So those are the main schemes in the market. And then we've got the administrator market. The administrator market is linked to the scheme market. So they do the administration for the schemes, and also largely we find that most of the administrators do the negotiations for tariffs and the contracting of practitioners. And then the main administrators that we have is Discovery Health at 40.4%, Med Scheme at 38.6%, and Momentum Health at 4.6%. So with regard to their interaction, so we've got the practitioner at the top right there.
May I just ask a question about the previous slide?
Okay.
So when you are calculating the market share of the administrators, I'm just trying to figure out how to formulate the question, because we know that Discovery Health administers a number of schemes, and obviously Med Scheme does the same. Is that determined by the number of members they represent? Is that market share determined by the number of members they negotiate on behalf of?
Yes, so that figure would include all the schemes that Discovery Health, the administrator, negotiates for.
Okay.
Okay, so in terms of industry interaction, we've got the practitioners at the top right. The practitioners interact with the consumers in terms of provision of healthcare services. In terms of their relationship with funders, it's largely determined by the tariff determination processes, the preferred provider network, and the reimbursement models between the funder and the practitioners. The practitioners also interact with the healthcare facilities, where they have lease or rental agreements, I'm Dr. Ramokhopa. I need to practice at a particular facility, so I'll approach the facility and negotiate a rental agreement. In some instances, you find that facilities or practitioners have shareholding in the facilities where they operate. They will grant them a particular shareholding. Alternatively, you have facilities that have been set up by the practitioners, and in that regard, they will then have shareholding in the facilities. There are also other financial incentives between the facilities and the practitioners. It may be in terms of them providing equipment, providing the practitioners with relocation fees or support or assistance or study loans and the like. This also influences how the practitioners relate to the facilities. Then the facilities on the other side will then also interact with the funders in terms of tariff determination and then being part of designated provider networks and also reimbursement models. So I'm going to focus now on the interaction between practitioners and funders. So practitioners interact with medical funders in the following ways. Practitioners and GPs, there's GPs and specialists would provide services to the insured patients. The medical funders will reimburse the practitioners for the services provided. The medical funders contract practitioners to preferred provider networks. What it means is that medical funders will go out to the market and invite practitioners to participate in networks. They agree on the terms and conditions of contracting, and this is where you'd find that the funders will channel the patients to those providers that have been contracted through this process. So you'd find that, let's for argument's sake, if you are on a particular benefit of a medical scheme, they will say, these are the doctors that are on our network, you can only go to these doctors. If you don't go to these doctors, then it can attract an out-of-pocket payment. So the funder will not reimburse in full, so you as the patient will then have to reimburse the remaining amount from your pocket. We've got also GP networks where it's similar. There's an overlap between preferred provider networks and these GP networks, where generally GPs are invited to be part of the network, and if they're part of the network, the funders will reimburse them in full. And then you've got direct contact where the price is determined at an individual level, and this happens largely where you have specialists that have some level of market power.
Can I just ask you about the preferred provider networks? Now, you've said that the funders and the doctors, medical practitioners, would agree the terms of a contract. But my understanding is that there is really no negotiation. You apply to get into a network, and when you get into the network, the terms are imposed by the scheme.
I was going to touch on that a little bit later.
Okay.
It depends on where the market power lies.
Yes, all right. You will still come to that.
Yeah, I'll come to that,
Okay.
Chair. Thank you. So lastly, the medical scheme benefit design influences how patients channel, how practitioners channel patients through the healthcare system. So your benefit design will tell you either you go directly to a GP, then the GP will refer you, but some plans, you've got a leeway to access the healthcare system whichever way you choose as a consumer, and it's largely your comprehensive plans that will allow you that freedom. But largely the lower cost plans is the ones that channel you into the healthcare system. So in terms of practitioner reimbursement models, you've got fee for service. Fee for service is where the practitioner will charge based on each service that is being provided. And then you've got fixed fees, global fees, capitation arrangement, those we call alternative reimbursement models, where a certain amount of a fee is agreed between the practitioner and the funder. And usually those alternative reimbursement models, they have some risk-sharing arrangement between the practitioner and the funders. And the extent to which these reimbursement models are applied are subject to the ethical rules of the HPCSA. For example, we know that the HPCSA in some instances prohibits the use of fixed fees, which we find to be pro-competitive in the sense that they minimize cost and they transfer risk between practitioners and the funders. And then funders use practice code numbering to verify and pay the practitioners, and also the prescribed minimum benefit regulations, which is like mandatory cover for prescribed minimum benefits that are payable at cost. So this will touch on the question that Chair asked. So tariff determination. Historically, tariffs were set collectively between Practitioner Association and the Funder Association. So at the time, I think the practitioners were represented by SAMA and the funders were represented by the BHF. We ended this practice in 2003 since we found the conduct to be anti-competitive and to be collusive. So since then, practitioners have determined tariffs in one of these 4 ways. So you have medical scheme administrators or scheme determining the fees that they're willing to pay the practitioners. So in this instance, a funder would say, these are my figures, this is how much you will charge my patients. Alternatively, you have a group of practitioner groupings who would then group themselves and approach the funders and negotiate the fees. Or you would have the practitioner grouping simply publishing the tariff guideline that the medical schemes will reimburse. Or you have a practitioner that may determine fees that they are willing to charge patients individually. The above are determined by the market power that lies on each side. So what we are finding is that the GPs in particular are price takers. They don't have much bargaining power against the funders, so they would be the ones that just simply take the price that is imposed by the medical schemes. So if we have to talk about the preferred provider networks, this is where the GPs will be told these are the terms and conditions of contracting, and simply because they don't have the bargaining power, they will accept the conditions that are imposed by the schemes.
And do you find this in respect of GPs across the country or GPs located in specific geographic regions?
The dynamics differ. So where you find GPs in locations where there is no competition, it gives them some level of bargaining power or market power. So in such instances, you find that GPs might be able to negotiate prices. But where you have GPs that are largely concentrated, or where you have a lot of GPs, there's a number of them, the bargaining power is relatively weak, and this is where they become price takers. And I think because our prohibition of collective arrangements, some GPs do not organize themselves to be able to increase their negotiating power, hence they become price takers.
Yes. I mean, when you talk about the price, what exactly does that mean? Because I asked another witness, it looks like when we talk about the price, we're talking really about 3 things. A price decided by the scheme, which is its own tariff, and then a price decided by a doctor to the patient, and then there's another price which is called the reference price, which is determined by the government.
The reference price, in our view, currently doesn't necessarily exist. There used to be a reference price after our prohibition of collective bargaining. There was a process between CMS, the Department of Health, and I think the Competition Commission was involved at some level, where a reference price was published. But there were a number of problems with the reference price list that was then taken to court and overturned by the court. So that reference price list is in theory there, but some practitioners use it, some practitioners don't use it. It doesn't really have any legal standing, as I understand. So you find that other practitioners still refer to it, others don't refer to that. As I say, some of these issues are determined by the market power and where the bargaining power lies. You've got practitioner associations who are able to group themselves and determine reference prices. So you can have a group of pediatricians grouping themselves and developing their own tariff guideline. But at the same time, you can have medical schemes saying, this is my price, these are my prices, and they impose those prices to the practitioners.
Yes, now, I mean, I'm trying to understand as I understand your broad point here, is that general practitioners are vulnerable to the market power by schemes. And so schemes impose a price. What price are the schemes imposing?
It's the prices that would have been determined by the schemes.
It's the tariff between the scheme and the doctor.
The scheme would have determined the price, and then when they go out to the market and to contract the GPs, they will say this is the price list. They will explain, I believe, their rationale for the price, and then this is what the GPs would have to charge.
Yes. You see, because that's the one price, but there's also another price between the GP and their own patient.
I believe that the price between the GP and the patient must be guided by what the scheme is willing to pay. If the GP or the practitioner believes that the price that the scheme will pay is not sufficient, they might charge the consumer a co-payment. So this is where the consumer will have to now, on top of what the scheme would have paid, they will have to top up with their own amount.
And what were you finding in your investigation? That GPs generally charge the exact amount that is decided by the scheme because the population that they service, in any event, doesn't have the ability to make the upward co-payment?
I mean, we didn't find a lot of deviation by the doctors from the amount that's been charged or that's been posed by the schemes, but we do know of unreported levels of out-of-pocket payment, and nobody has been able to properly estimate how much some GPs might feel they need to charge over and above what the schemes would have reimbursed.
So when you say you didn't find a lot of deviations, you mean, so I just want to make sure I understand this clearly. These schemes have a lot of power, especially over general practitioners. They impose the price, the general practitioners take the price, and you don't observe a lot of deviations. In other words, as a matter of common practice, doctors will charge precisely what the schemes want.
That's the main finding, especially in relation to the GPs.
Sorry, Mr. Ngcukaitobi, would your answer to that be different in relation to specialists?
No.
Slightly, it would be different, but we didn't go into really detail on this one. But we found that some specialist market have market power, and it's represented by their ability to unilaterally determine their own pricing, and schemes will be forced to accept the prices that would have been determined by the specialists.
And how would they have that power, that unilateral power? Would it be the nature of the specialization or the area in which they practice? What would it be?
It will be based on a number of factors. It would be where they practice, so you find that there is only one specialist in a town. They don't compete with anyone, so they are able to determine their own price that they will give to the medical schemes. There is also coordinated conduct, which is what I've got in it's a third point there, where they group themselves. It's a group of specialists, and they collude to say these are our prices, and then the scheme will have to take that price.
Can I also ask you something related to how this market power manifests? So the one is at the setting of the price, but there might be an argument that you've got an alternative. You can charge your patients directly.
Well, it depends. I mean, you can charge a patient up to a certain point. Especially if you're going to be dealing with largely patients from low-income backgrounds, there is a limit that you can charge. So it depends. There's an extent to which that you can exercise that power.
So even the idea that, because I want to understand what pressures the GPs are facing. So the one is the schemes are too powerful, they decide, but you really do not have an alternative because the population that you are servicing simply cannot pay.
Yeah, I think that those are the dynamics.
So just a question about the reference price list. It's not valid in law, we know, anymore, but it's sort of there, used in some way. And if that is the case, how has the reference price list been adjusted every year since it's been struck down?
So our understanding is that the practitioners who use that, some of them would just add inflation to what existed the previous years. Those that have market power, they may even add multiples of inflation to that reference price list. Again, some collude and use that price list to say, you know, these are our tariffs. And the medical schemes will have to then accept that.
So it would be most open to manipulation by those who have the market power.
Exactly.
So GPs, for example, wouldn't be able to really use multiples of inflation in order to adjust.
Yes. And I think I'll get to this in the recommendations, that this is one regulatory gap that we find that's contributing to this.
Thank you.
Yeah, I think I've already covered these 3 points. But I think one of the also main thing, you don't find GPs refusing to participate in provider or DSP arrangements, but definitely some specialists do refuse to participate in those arrangements. So tariff determination is also linked to clinical coding. So coding is linked to tariffs. In order to come up with a tariff, especially in a fee-for-service environment, each activity performed by a practitioner has to be labeled, and this process is called coding. It translates medical information of patients' interaction with healthcare providers into alphanumeric codes. It provides a form of standard communication that identifies which procedures, diagnosis, or services have been delivered. So codes form the basis in which tariffs are determined. So,
sorry, Ms. Ramahopo, can I interrupt there? Could you just explain, and excuse my ignorance, but what is an alphanumeric code?
So these are they're typically called ICD-10 codes in the market. So you go to a doctor, he diagnoses you with a particular condition. That condition will be then be classified in terms of a code. So it helps the funders as well identify the services provided and then also reimburse the services provided.
So it's definitely a diagnostic code?
It's a diagnostic code, okay. Yes.
And then how does that translate into determining your tariff? Because obviously let's just assume someone is using a variant of the RPL or the NHRPL, and there's a description in there as to a procedure performed. Is there any correlation between what the ICD-10 code says about diagnosis and what the reference price list or the NHRPL says about the service performed?
I'm not sure about that, but there is a link. So I think the tariff guides or the tariff, the RPL, the reference list, right, would be based on the ICD-10 codes or the diagnostic codes. So it informs what services would be provided and how much would be paid by the funders. I hope I've answered that clearly. And then you've got interaction between healthcare facilities and practitioners. So practitioners refer patients on an inpatient or outpatient basis to healthcare facilities. Medical funders will then reimburse both the practitioners and facilities in separate accounts. Practitioners have various relationships and contracts with facilities. As I mentioned earlier, so they lease rent a practice room from facilities. They have shareholding in health facilities, and there are also other financial incentives between practitioners and the facilities. All of these are subject to the ethical rules of the HPCSA. In terms of the competition dynamics from the interactions that we've just outlined, these are the ones that serve to create an imbalance in practitioner relationships with patients and their funders. So between patient and the practitioner, there is what we call information asymmetry. What it means is that largely the consumer doesn't know the services that they're providing, so they're already at the disadvantage because they are even unable to negotiate the price or to be able to inform the services that they are purchasing. Also, you have moral hazard, where you find that patients, because they are covered by medical aid, they will unnecessarily require care, and doctors may be overcautious in some instances and also overtreat when it's not necessary to overtreat. In South Africa in particular, we find that there's fragmentation of care, where you have practitioners operating in silos. There is no integrated care, where you find that you have primary care practitioners, they're linked to specialists and facilities, and products are being provided in an integrated way. So everybody does things on their own, and it results in a lot of wastage in the market. In terms of regulatory failures, the key problem in the South African market is a lack of supply-side regulator. The supply-side regulator being the regulator of the healthcare practitioners and the facilities. One might argue that the HPCSA exists to regulate the practitioners, but there are many regulatory gaps in the HPCSA mandate. One of the key things that we find is that post our intervention in 2004, we'd hoped that the sector would develop some tariff determination process and guidelines for practitioners, and this would alleviate the problem where there is market power dynamics between the funders and the practitioners, or market power dynamics between specialists and the funders. So it is important that some tariff guideline be determined, but this cannot be determined by the market. It has to be a regulatory process. We also find that there's persistence of fee-for-service tariff determination, where there is no risk-sharing models between funders. We prefer bundled or alternative reimbursement models that are generally cost-effective, and they transfer risk between the interacting parties. The PMB regime that requires reimbursement at cost for all the services provided, it decertifies overutilization of services, particularly hospice-centric services. Even the benefit design, the way it's structured, it incentivizes overutilization. There is also lack of outcomes and quality reporting by practitioners, even facilities for that matter. So one of the key recommendations that we want to say is that there must be some level of outcomes and quality reporting, and practitioners are able to use that for peer review to see where there's unnecessary wastage and cost. Even the funders are able to monitor properly what is happening in the provider market. Currently, funders have their own systems of assessing quality or outcomes, or examining whether there's fraud or wastage, but the process is not transparent. It happens largely within the funding market, and in some instances it's seen as a competitive advantage to certain funders, whereas if the process was public, everybody could be able to assess exactly what the funders see as wastage, as fraud, and maybe unnecessary utilization. And the other regulatory failure that we find is that the ethical rules, they are outdated. They don't promote sort of novel and innovative models of care, and this is one of the reasons that we find that there is higher utilization in the market. The incentive structures and exclusionary practices. There are shareholding and lease agreements and other financial incentives that we find are exclusionary, particularly towards historically disadvantaged practitioners and new entrants. The large number of contracts that we reviewed, or shareholding contracts or lease contracts, we find them to be very exclusive, and this operates on the other side as well. So new hospitals that want to enter the market, they also struggle to attract practitioners, because practitioners are bound by these shareholding and lease agreements, which are largely exclusive.
Can you expand a little more on what you mean by exclusive?
So you would find a lease agreement which says that a practitioner can only operate in this facility and cannot operate in other facilities that are within a particular radius of that facility. Also, you find that there are long-standing agreements between the facilities and some practitioners, such as new practitioners that have just qualified may struggle to access those facilities.
I mean, in what way are they racially exclusionary?
Yes, Chair, as we have earlier indicated, we have not really done a deep analysis of that, but there is a correlation often between race and entry, because the incumbents tend to be white, and as I have, we will submit to you in the end the types of complaints we have received indicate this, because we get a lot of complaints from practitioners who want to access facilities, and these will tend to be new entrants, and they would largely tend to be black entrants.
Thank you.
And then also the practice numbering system, we find that as well it's inefficient and it's exclusionary. There are practitioners that approached us to say that they struggle to get, especially the new entrants, they struggle to be allocated a practice number, and if you don't have a practice number, you cannot bill, or you may not be reimbursed. And then the coding, again, a regulatory failure in the sense that this is generally, when you look at international market, a government responsibility. So we don't have a structured coding system that can be used across the board. Instead, practitioner groupings such as SAMA would then develop a coding system that may not be accessible to all the practitioners in the market.
May I just ask you to expand on that, this issue of coding, because it's some concern in relation to the issues that are arising in this. Let me think how to phrase the question. Two parts of the question. How many coding systems are there at play, do you know? And is there such a thing as the correct code to describe, let's say, treatment, for want of a better word? And if you don't know the answers, it's fine, just asking the question.
Okay, no, that's fine. We don't know how many there are, but we know there are numerous in the market that are being used by various practitioner groupings. And based on international practice, this would be determined by maybe government in consultation with stakeholders, and there will be a standard coding list that is used by all the practitioners. And through interactions, as the market change, it may be updated, but it's in consultation with all the industry stakeholders, but government or the departments will be the custodian of the codes.
So you're talking about the ideal there?
This is the ideal, which we don't have in South Africa.
So the practical reality is numerous, both claimed by, let's say, private and public sector entities.
Yeah.
And sorry, my second question, which was, is there such a thing as the correct code to describe a particular service or treatment?
I'm not sure about that, but I do believe that maybe through an industry engagement, an acceptable code can be determined.
And the ICD-10 codes, isn't that a code that is most in use by most practitioners? So while there might be, isn't that the default, if I might call it that?
Yes, you're correct. The ICD-10 codes are the default. Okay. Yeah, so as I mentioned, most of these dynamics impact on new, smaller entrants. and we find that most of them will tend to be historically disadvantaged practitioners that struggle to access the market. So one of our key findings in the provisional findings report was overutilization, which sometimes may be seen as fraud in the market. And we raised concerns that the funders in particular are not managing the overutilization of healthcare services properly and in the interest of the consumer. So we've seen recent developments by the funders to try and manage overutilization, and we welcome this initiative. However, there must be a balance between managing overutilization and exclusion of smaller and new entrants, and who might not be as sophisticated and are still trying to penetrate the market. So there must be a balance. And generally, we believe that some of the dynamics are simply because of some of the structural problems that we have because of the regulatory gaps, and these may be addressed by some of the structural reforms that we propose to try and drive down costs and cap overutilization and fraud. So these are our proposed interventions, and they largely affect the practitioner market. There are other ones, but these are targeted at the practitioner market. So we proposed an urgent review of the HPCSA rules to enable integrated and innovative models of care, to allow for global fees and alternative reimbursement models, and improved monitoring of contracts and incentives between practitioners and facilities. I think this is important in the context of exclusion that I spoke about. We found that the HPCSA really doesn't monitor the contracts that exist in the market between some of the incumbent hospitals and the practitioners. And some of these contracts are long-standing, but they've never been reviewed by the HPCSA. And understandably so, maybe because they don't have any legal or regulatory authority over the facility market. So a review of these rules to enable that monitoring will be important. Tariff determination framework. We need to start moving away from fee-for-service and have a reference price list with maximum price for prescribed minimum benefits implemented. This needs to be done through a public process managed by a regulator. We need to have a review of a coding. We also proposed a review of the PMB regulations. We understand that the process is already underway, and also a standard benefit design that will redefine the healthcare pathway, promote primary and preventative care, and again we emphasize the important role of the GP, which is lacking in South Africa. The GP should be the gatekeeper to the healthcare system. We recommend outcomes reporting. This is where we can have a system of collecting quality indicators, auditing and reporting. It enables peer review. It will cap overuse and fraud. If we are a group of practitioners and we see that other practitioners in Limpopo are practicing in this way and it's leading to good outcomes, we are able to reflect on that. The practice numbering system, we propose that it be reviewed and primarily it be removed from the mandate of the BHF. It should be a regulatory process, and this should ensure that there is no exclusion embedded in the process. Thank you, Chair.
Chair, if I may just now start concluding. As my colleague has indicated, we are recommending many structural reforms to promote access and entry into the market. We think that this is more of a problem of a system, and we would recommend a systematic approach to its resolution. We understand there may be individual instances where you may want to dwell into the specifics of that individual case. But from our point of view, we think that there are ways in which one can develop a system that ensures that the new entrants are able to get into the sector and access critical facilities. And we think that crucial to this is the establishment of a supply-side regulator that should be empowered to deal with these issues of access and indeed the other moral hazard of overutilization, because one has to be careful to strike a balance between protecting practitioners but also protecting patients, whom we have indicated are often the weakest link in the chain because of information asymmetry. We have also accepted, I hope we have made it clear, that we accept that GPs in particular, amongst those who are kind of bargaining in the value chain, because the patient doesn't even bargain, but at least amongst those who have a potential to bargain, the GP is probably the weakest. And so whatever system is designed, I think we'll have to take into account their position in the market, which is that of a price taker. We think that, as we have indicated, the crucial to this must be a transparent way of measuring performance, outcomes, and quality, so that you don't have practitioners who are successful not because of merit, but because they are either incumbents or are favored as a result of all these relationships we have outlined that cause some perverse incentives. So I think one can introduce some meritocracy in the system. I think the last thing we've said is that also the issue of risk sharing between funders and practitioners is quite important, as right now funders assume no responsibility at all for the outcomes. And we think that this will be necessary to achieve the universal health coverage. And then lastly, Chair, what we have done is we have provided just a list of complaints we have received over the years from 2015. I will just not mention these here because I don't know if the complainants would be comfortable, and we have not consulted them. But just to illustrate the gravitas of the problem, from 2015 to now 2019 years, we have seen an increase in the number of complaints by 244%. 2015 we recorded 9%. This is now amongst all the complaints we received at the Commission. The following year, we received, that is 2016-2017 year, we received 12 complaints. 2017-2018, we received 17 complaints. 2018-2019, we received 31 complaints. So they are clearly increasing, and they typically would be about exclusionary agreements between private hospitals and service providers. There are a number of complaints from healthcare service providers who provide things like renal and Pathology Services who allege this exclusionary act. We've had people, for an example, who want to provide even optometry and other services who are not able to locate at the hospitals. We have also received some complaints about the DSP arrangements, who feel, providers who feel that they have been unfairly excluded as a result of these contracts. We have, as I've indicated, tabulated all of these, and we've given you the names. I think if you are inclined to utilize them, we can check if the complainants would be comfortable with their names appearing in public reports. Thank you very much, Chair. That is it from our side.
Thank you. Yeah,
it's a question for Ms. Ramokgopa, and it's about the tariffs again. And in the report, there's reference to Healthman Consulting, who was commissioned to prepare some tariff guidelines. And then there was a complaint that was brought by BHF to the Commission. I just wanted to know, one, what was the outcome of the complaint? And two, what is your understanding of the role that Healthman Consulting played? Meaning, was there any benefit to having those guidelines, and should they be continued?
So we investigated the Healthman complaint. That was just before the commencement of the inquiry. And we had non-referred the complaint not on the basis that there was no wrongdoing, but we wanted to look at all the structural issues around price determination in the healthcare market. Our understanding is that Healthman is a consultant that collects cost information on behalf of practitioners, and on the basis of that advises the practitioners what prices they can charge or assist them with the tariff determination. And preliminary, we thought that conduct is anti-competitive, but it was important to locate.
As anti-competitive? Anti-competitive.
It was important to locate the conduct within the context of the lack of a mandatory or sort of a regulated tariff list. And practitioners then resort to this kind of conduct because there is nothing that guides them in terms of tariff determination. So although it might be anti-competitive, but it must be located within the broader context of price determination and the lack of a proper tariff guideline in the market.
Thank you, Mr. Commissioner. I just wanted to ask you. So if we take your position seriously, that the problem is a structural one, and if we are to approach it, we need a systemic intervention. And the problem that you've identified is over-concentration of power on the part of schemes and lack of market power on the part of general practitioners who are individual, isolated, and often find themselves vulnerable and exposed. But they are not able to organize in order to bargain for a better relationship with the schemes. What is the structural intervention necessary to regulate that relationship?
Chair, maybe I'll start with the acceptance on the part of the Commission that the intervention we made did serve to weaken those who are weaker in the system. So the bargaining was useful as far as you had a lot of GPs who are scattered, than say it was useful for facilities who are concentrated, or funders who also are largely concentrated. So we accept that the regulator will have to step in to rebalance that. Now, you may accept that it's a contravention of competition law as it is currently framed, but it doesn't mean that you don't recognize the problem. I think we recognize the problem that the GPs do need to be strengthened in the system. And that may include, for example, allowing them to bargain together through some form of a legislative intervention or some other regulatory intervention, or, as we have indicated, a tariff that is prescribed by an independent body that would obviate the need for the bargaining process. So those options are there. I think that the one-size-fits-all intervention of competition law is not helpful in a sector like this because it does lead to inequitable outcomes, and that we have accepted. But there is a caution, as I've indicated earlier, which is that of protecting the patient as well as you do that, because as you strengthen the doctor, you need to recognize that the patient may also be ultimately be the one that is exploited. So I think one needs to be very careful about whatever system that is introduced. If it's a tariff, it's got to have independent people, for an example, who are involved in the determination of the tariff, rather than just have doctors themselves alone making that determination. If it's a bargaining, you also need to have a system of safeguarding the doctors who may be strengthened, but could also simply be captured by the funders, there is a history sometimes of those who are weak being strengthened only to identify a commonality of interest with those who are stronger. Certainly, these are some of the arguments that have been used with the funders when they bargain, or when they used to bargain with the hospital groups, that instead of the funders playing the role of bargaining on behalf of the insured patients, that they could have identified a commonality of interest between themselves and the hospital groups. So that is also not unthinkable in the case of doctors. But I think that one would have to think very carefully, and we think that the starting point is perhaps an acceptance that there needs to be a regulator, a supply-side regulator, that will consider all of these things, that would conduct research, that would lead into evidence-based interventions.
One of the things we had earlier, we had a number of medical practitioners who are part of solutionist thinkers, is a concern about information sharing, that the schemes share information around medical practitioners that are perceived to be outliers, and that is a problem. I mean, their perception is that that's itself racially loaded. I don't know if it is or it's not. But I wonder if there are no other competition concerns relating to information sharing among the schemes.
Chair, the schemes are very concentrated. Yeah. So I do wonder whether that for us is a significant concern. For example, if you just look at Discovery, it doesn't need to share information with anybody for it to exercise market power. So maybe if that is a concern at all, it may apply to smaller schemes. But we are more concerned with market power, and the concentration, just the mere concentration there, suggests that everything else is less important. You already have a person who doesn't need to share information with anybody who can exploit that power, and that's perhaps why you need a regulator.
I'd like to ask you about your recommendations in relation to the funders. And just wanted to know if you could expand a little bit on the relationship between schemes and administrators. We know that we've seen what you've presented about the market share that schemes have as a grouping and administrators as their own grouping. But there's an important relationship between the schemes and the administrators. And I just wanted to pick out a few things which I'd like you to address us on, if you're able to. Well, we know who the big players are, so let's not go there. One of the findings was that a failure of governance that aligned scheme interests too closely with that of administrators. That was something that was a cause for concern. If you could address that in a little bit more detail. Secondly, related to that, of course, is the capacity of administrators versus schemes. Analytical capacity, investigative capacity, whatever it is. So that relationship between scheme and administrators is something I'm trying to probe with you. And then finally, this, which I'm going to quote from the Competition Commission's the panel's provisional report, is the following. We find no evidence that schemes demand information on the costs saved by administrators related to, for example, managed care or fraud control, and whether the related savings are passed on to scheme members. So we know that the responsibility for managing fraud and waste is with the administrators. But this suggests that the schemes are not demanding something from the administrators which they ought to be demanding, which is that the savings are passed on to the schemes. Am I understanding that correctly? And if I'm wrong, please feel free to say so.
Just a minor disclaimer, those were the provisional findings, and we engaged with stakeholders, and the final position on these issues will be in the final report. But I think your understanding is correct. We didn't find that the schemes, in particular the trustees, their efforts were aligned to the interests of the consumer. And we found that there were no mechanisms, particularly from the regulatory side, that will force the schemes and the trustees to act in the best interest of the consumers. So just a simple example around bargaining, you don't see schemes going out and say, we want to bargain at a price less inflation. So the target is always, above inflation. You don't see that effort to drive costs down. You don't see effort to manage utilization, and the responsibility is just the administrators really can just go into the market and bargain, not really protecting the interests of the scheme, of the consumers, and it's simply because there are no accountability mechanisms between the administrators and the schemes that are enforced by the law. Administrators have no accountability towards the members of the schemes, hence, but they go out and negotiate for the patients. So those are some of the governance issues that we've picked up, and then we've made recommendations that some of these governance issues must be addressed. Even in terms of the evidence from the managed care organizations that exist in the market, we don't see outcomes of those managed care arrangements. They are not transparent. They are not published we understand that there's some reporting that is done to the Council of Medical Schemes, but the process doesn't seem to be transparent, that we feel that the interest of the consumer is protected by those arrangements. So your understanding is correct, and the final position by the panel will be reflected in the final report.
Okay. What does that actually mean in practice? So, as I understand the theory that you are coming with, it is that, look, We say as the Commission, there is overutilization and there is fraud, and that is ultimately harmful to consumers, right? So that's your first premise. And then you say, well, then you have a duty to make sure you sort out overutilization and then you sort out fraud. And that's what the schemes are claiming to be doing. But what is coming up is that even though the schemes recover some money as a result of overutilization and fraud, no one knows what happens to that money.
Yes, so there is no transparent process where the benefits of those can be interrogated by the broader public. And even in terms of the cost, you don't see that passed down to the consumer. And we didn't find proper evidence of this, but we suspect that it's because of the complex relationship between the administrators and the schemes. But I think also we need to distinguish between overutilization, over-servicing, and frank fraud. I mean, I think there is frank fraud that is something else to what we investigated. We looked at overutilization.
Yes, but I mean, you would say on both, if you recover from overutilization and you recover from fraud, there must still be a benefit to the members, and that's the problem you say you've identified.
Yes, I mean, you don't even see it in terms of reduced premiums. The premiums keep on increasing every month. So all these savings, we don't see them being passed on to the consumer.
If I may, with your permission, Chair, the issue of utilization has to be addressed through incentives. It should not be there at all if the incentives are correct. So that is another systemic issue. I mean, I don't know about fraud. I think fraud is a little bit harder when you have people who just break the law. I don't know if you'll ever be able to eliminate that completely. But it seems to us that we should at least change the incentives for overutilization. And I think the report is quite clear that South Africa is really an outlier when it comes to this. So even if we don't eliminate it completely, but just bringing us down to the level where everybody else is at will make a huge difference. So it seems again there we have a systemic problem, and as my colleagues suggest, the part of this could be just the design of the relationship between administrators and schemes. This is a typical case where the policy and outcomes are not in sync, because it was never envisaged that the administrators would be so powerful in the system, and that the schemes would be so weak, because it was all premised on people participating in schemes, meetings, and holding administrators accountable. But we now know that system has not worked at all, and we need to introduce something else in the system to correct for that problem.
May I just ask a point of clarity, just so I understand kind of the full weight of your submission? Am I correct to summarize, part of the submission is that the Commission views the cost savings that come from administrators and managed healthcare's methods to tackle fraud, waste and abuse. So the Commission reviews the cost savings as not bringing consumer benefit because it isn't leading to prices going down in the market.
That's correct. We don't see any evidence of that.
And just for fullness of debate, as I imagine the schemes and the administrators at some point will make submissions on this and will argue that there is a benefit in terms of premiums not going up more than they already are. How would you respond to that?
I think our submission is that the fact that the process is not transparent, it's very difficult to interrogate whether premiums would have gone up or been lessened. If there was a mechanism where the costs, the savings, and are fully available it would be easy to interrogate that. But at this point, with the information that we received, we didn't see any benefit.
All right. Thank you. I believe that will be all from the panel. Mr. Commissioner, it remains for me to thank you and your team for coming and presenting. Your presentation will no doubt enrich the work of the panel. I presume that your slides have been shared with the Secretariat. I see somebody nodding, so that probably means
But
yes.
this side is nodding and that side is shaking their head.
But it is available, Chair. If it's not been made available, we certainly will make it available together with the list of complaints.
The list of complaints, yes. All right. Thank you very much. That will be the end of today. We should commence again tomorrow at 10 o'clock, hopefully promptly. I can't remember who's presenting tomorrow. Okay, CMS. All right, I'm sure CMS will keep to the time. All right, thank you. We are adjourned for the day.